Nice to meet you too, Cam. Oh, good. Well, I'm honored to be here. Thank you. Yeah, it's really become even more common in the U.S., particularly with weight loss. I think in the U.S., massive weight loss is probably more common than it is here in Korea. But that patient population has increased the number of patients that I see for both augmentation and mastopexy because they typically have almost no volume after they've lost, 100 pounds or more, and they always have a significant degree of ptosis. So it's in the 22 years that I've been in practice, I think I'm seeing more augmentation mastopexy patients now than I was at the beginning of my practice. That's probably, it kind of depends. So if you're talking about the massive weight loss population, they're almost all augmentation mastopexy. In the non-massive weight loss patients, probably about 75% just mastopexy and about 25% augmentation and mastopexy. Yeah, same, and that's why I think it's really, really important to show a lot of photos. But yeah, a lot of times I think you have to try to talk to them about what the alternative is. Because I think a lot of patients think that they're gonna look just fine with just implants. And they say, no, I don't want the lift, I just wanna have the augmentation. And unfortunately, I don't have a lot of patients to show them because we just don't do that. We have some illustrations. I try to show them sort of their own anatomy in illustrations about the relative position of the gland and the implant. And if those two things are not aligned with one another, the shape is going to be, really terrible. So it's just a matter of communicating with them and saying, I believe that the scars are going to be justified because you're going to have a beautiful shape. And if you can show them a lot of patients that have really an ideal breast shape with beautiful volume, then the scars tend to not be as big of a problem. But at the end of the day, it's up to the patient to decide. And I have had patients that have said, no, I'm not willing to have those scars. And in those cases, I typically just recommend they not have any surgery at all because I don't want to put implants in and have them be unhappy. Yeah, I do. There are some patients that I will stage. About 90% of mine I will do in a single stage. The ones that I will stage are patients that have a very, very severe degree of ptosis. Often, again, the massive weight loss patients, the post-bariatric surgery patients. But for the typical the typical patient for me is a woman maybe in her 30s who's had children and maybe has a little bit of postpartum deflation and ptosis. Those patients I will do in a single stage. I'm very careful though. My opinion of how to do the operation in one stage is to set the volume first. So I know some people do the mastopexy first and then add the implant. I do it the other way around. So I will add the implant and then I'll sit them up in the operating room and then I'll confirm my markings. And sometimes you have to change them. Sometimes, we've gotten pretty good at planning for the markings, but you really want to confirm once the volume has been set that your markings are accurate before you commit to them. And since I've been doing that, revisions are pretty uncommon. Yeah, I think if you can get a nice shape with the perireal or mastopexy, obviously that's going to be the best result because then you get both. You get an improved shape and you avoid the vertical scar. I use an inferior pedicle. But it's really, honestly, it's a central pedicle because I'm not elevating the gland off of the muscle. No, I still do an inferior pedicle. And I actually have in my talk, I did a case last Friday, a week ago.
Okay.
And so I took photos of each stage, and I've incorporated them into my talk. But I still do, I insert the implant through a lateral incision, and then I leave the rest of the medial pedicle, the medial aspect of the inferior pedicle, excuse me. And again, because I'm preserving the central component to it, I just don't see